Thank you very much. And before starting at the outset itself, let me thank the organizers, especially Peter Hillman, Professor Hillman, for inviting or giving us the opportunity to talk on how we manage CLL in India. My job is made much simpler because previous two speakers have already, there are a lot of similarities, or it's almost the same story. When I'm talking through this, you'll understand that I have no conflict of interest too. So the next 15 minutes or so, my main intention is to focus on a few things, mainly to identify the difference in epidemiology, biology, and how we manage CLL in India. As you already mentioned, my background in both UK system and Indian system has helped me a lot in this attempt. So if I search through the literature for CLL, if I type the word in PubMed for chronic lymphocytic leukemia, then I'll get around 25,000 articles or 25,000 hits. But if I confine that to Indian context, I'll hardly get around 150 articles. This shows the lack of quality research that's coming out of India in CLL, and similarly from Africa and South America that we've just heard. To try and find the incidence of CLL in India is extremely difficult due to the same reason: lack of epidemiological data, lack of quality registries, non-unified health system. Everything contributes to the lack of knowledge in epidemiology in India as well. So to understand the incidence of India, to understand the incidence of incidence of CLL in India, if I search through the literature, I'll come across a few articles. These are all case or retrospective audits from case records from the hospitals, which is decades back, and some of them in the later decades. I could get around 7 or 8 articles I could find, and I could get the details of around 3 articles. And all of this has reported a low incidence of CLL among leukemia in India compared to the Western literature. So a more recent study from All India Institute of Medical Science, which is one of the premium institute of India, which sees around 4,000 new patients and 17,500 follow-up patients in hematology every year around the period the study was carried out. So they did a retrospective case note analysis for over 11 years and found only 95 patients. But note that around 50 to 60% of patients only require treatment. So they picked up asymptomatic CLL as well in this study. Now, as my previous speaker from Latin America was saying, we also looked at the review literature on what the incidence of CLL among the non-Hodgkin's lymphoma. And there are 3 studies, all of which has reported an incidence between 3 and 5, compared to something like 22% from US. But of note, most of the Eastern world has noted to have a low incidence of CLL among non-Hodgkin's lymphoma. Especially, this has to be taken into context that Japan also has reported a low incidence of CLL, where I would imagine that the healthcare is probably comparable to most of the Western world. Of note, this study carries some importance. This is one I could get from UK, where the ethnic diversity of the incidence of CLL was studied among the population of England from 2001 to 2007. And it is also reported a low incidence of CLL among the Indian population compared to the Caucasian population. But it has to be noted that this incidence is higher than the incidence of leukemia reported by Globocan and the cancer incidence of 5 continents in the study. Oh, this job is made easy. Pete already mentioned about this study. This is from a Ugandan population, so incidence of finding MBL compared to Caucasian populations, age-matched Caucasian populations. This is to be doing the study independent of the healthcare provision. And as Pete mentioned, we found a similar incidence of MBL in both Ugandan and Caucasian population, but something has to be noticed here is that the phenotype is completely different. In Caucasian population, it's more of CLL-like phenotype, but in Ugandan population, it's more of like CD5 negative MBL. Again, this slide is made easy. Pete's already read my mind, I think. He's already mentioned this. The incidence of CLL really low in Indian population? This has to be taken into the context that, in majority of these countries, as we already heard, the only symptomatic patients come to medical attention. Asymptomatic picking up of CLL through routine blood test for another reason is extremely rare in Indian context. It's only limited to the wealthy urban population in Indian context. And again, this is what he mentioned before. The median age of CLL is around 72, but the average lifespan of Indians is only below the median age. It's around, it varies from different regions of India, but it's definitely below the median age of occurrence of CLL. India, as you've seen in South America, India is a land of diversity. Even though it's just one country, it's a land of diversity. It has got around 1.34 billion people according to 2017 census. It's still increasing. There are around 29 states. It has changed recently. 17 major languages, different dialects. People vary in every aspect. Even though we all call Indians, we vary in several things. Most of the things: language, race, culture, ethnic background. There are a lot of diversity in Indian population, and socioeconomic diversity is probably one of the most important hindrance of delivering healthcare to Indian population. It's around 72% of the Indian population live in rural villages where the healthcare delivery is extremely difficult. So this is the structure of healthcare system in India. So I'm sorry that it's a busy slide, but I'm not intending to go through the whole slide. This is something that I got from the Commonwealth Fund data. In India, both central and state government play a crucial role in both policy making as well as delivering the healthcare. And public system is it's a combination of India. Healthcare is a combination of public and private sector, and in public system, financing is by general tax revenue, like in UK. But private insurance role play a very, very limited role in India. Even with government schemes, it only play around 20% role in the total health management of health expenditure of Indian patients. Primary care delivery, especially in the rural setting, is done by the public sector, which is highly fragmented and inadequate. In the urban population, there is much more healthcare delivery because people who are wealthy and rich, who can afford health insurance, or really who can pay out of their pocket. So, as I said in the slide, 70% of the health expenditure is out of pocket, and per capita spending for health is only $215 when it's compared. This is 2014 when it's compared to something like 9,000 probably for the US, and somewhere between 4,000 and 5,000 across the countries in Europe. And around 63 million Indian people face with impoverishment every year because of the catastrophic healthcare cost. So I just have to highlight that, I was hearing Matt David's talk before. If you go through serial, treatment with targeted therapy of, like he was mentioning about 3 targeted therapy, people will not die of CLL, but definitely their 3 generation will die of starvation. And then above all this, a huge number of Indian population is catered by indigenous and traditional style of practices, which is unscientific, like Ayurveda, Siddha, Homeo, whatever you name it. And to divert patients from these sort of culture is extremely difficult in Indian circumstances. So it's not a highly complicated heat map. It's still a heat map on the DALI, disability adjusted life year of changing disease burden across India. You can see that as with the Western population, the communicable disease is giving way to non-communicable disease now. So the darker the shade in here, the increase of DALI over 1990 to 2017. So in communicable disease, that's the brown shades. You can see that HIV and dengue is only increasing. Rest of the communicable disease is actually coming down. But in non-communicable disease, almost everything is going up, including leukemia. So now trying to identify the difference in biology of disease, I couldn't find anything except for a 2016 ASH abstract, again from All India Institute of Medical Science, I have to say, which has reported a higher incidence of poor prognostic markers, especially 17p deletion and mutation. But I couldn't find any other article to substantiate this or support this evidence. Now, coming to the management of CLL in India, I was trying to identify or find some guidelines on Indian, how we should treat the Indian patients, because I'm trained in UK, and when I was going, to practice in India, I was trying to find some guidelines. So this is National Cancer Grid guideline. This National Cancer Grid is actually a network of cancer hospitals, research institutes, patient community, and NGOs to unify the cancer care across India. And I could see that they have grouped CLL into other non-Hodgkin's lymphoma and just advised to treat CLL similar to non-Hodgkin's lymphoma, CVPR, CHOPR, and just advised in CLL, FCR or ofatumumab chlorambucil can be used. So another document from an expert group in 2018, this is quite late now, 2018 by an Indian expert group in lymphoma management. Again, their guidelines is going in par with probably international guidelines. But look at the list: newer therapy option, ibrutinib, venetoclax, idelalisib. It's not even available. Ibrutinib is available, but venetoclax and other newer agents are not available. So what is the practical application of putting a guideline like this for Indian context? Now, having said all this, I was trying to identify some real-world data on Indian patients. But when I was given this talk, I was trying to identify, because my experience in Indian system is not that long. So I seek the help of one of my colleagues in one of the biggest private hospitals in Delhi. When I'm saying this, this is not a representation of India. This probably is the best case scenario in India. Medanda is 1,250 bedded hospital, which is a very corporate hospital, for-profit hospital. Patients pay out of their pocket or have private health insurance. We tried to retrieve case records through electronic case record, and 2009 to 19, we could identify 124 cases. That's all that we could get. Median age is 69, male-female ratio is 3:1. Cytogenetics was done in around 32%, and 17p was found to be a little bit more, 14.2% more than what is reported. So again, patient requiring treatment, anemia and progressive lymphocytosis was the main indication. 70% had first-line treatments, 25% had second-line, 11% had third-line, and 6 had subsequent lines of treatment. 7 patients have major infections for which they actually require hospital admissions. Now, what do we treat patients with? That's a big question for India, because availability and licensing and availability there's a huge difference between. So this is the best case scenario, as I said. They use FCR in around 14 patients of less than 60 years. So out of 24 patients, they used 14 FCR, and 7 had BR and various other treatments. And more than 60, predominant treatment again is BR, and then chlorambucil with or without monoclonal antibodies. Second line treatment, again, predominant treatment is with bendamustine. They have used ibrutinib and FCR in some patients. Now, trying to calculate the survival, this is the most difficult bit in case record, retrospective case record audits. Even though the data is for 10 years, the median follow-up I could get is only for 2 years, 23 months, because most of patients are lost to follow-up because they shop around. Once they're treated in Medanda, they are, they've spent almost all their fortune, and they'll go to some other, hospitals where they couldn't have. So we are lacking data in that. So the follow-up is almost absolutely impossible for these patients. Now, because as I said before, my experience in India is few years, but I was trying to get what the people who are experienced and people who have been practicing CLL in India has been doing, and how do they feel. And so I plan to do a survey on survey with including clinicians who has been treating CLL in India for a long time. So both hematologists and medical oncologists treat CLL in India. There's no regulation who treats. Physicians also can treat sometimes. So there's no regulation in India. So around 56% patients. This is a Google form survey, which had around 23 questions and 10-15 minute survey. So I rolled it out around 188 clinicians, but only 25 responded. But among half were oncologists and half were hematologists. The experience varied from 5 years to 44 years, and the response was mainly from the South Indian states. One of the states is where I'm from, and 80% don't think that CLL is common as it's seen in the Western population. And of what percentage of CLL, what percentage of leukemia is CLL, most of them answer to a median of around 10, varying from 2 to 25. And total patient of their total patients, 5% were CLL. New patients seen annually was around 10. Relapsed patients seen annually was only 5. Percentage of new patients less than 65 was 30%, and percentage of relapsed patients less than 65 is 25, and around 50% in their practice require treatment. Now they use flow cytometry. Most of them said they use flow cytometry for peripheral blood flow cytometry for diagnosis of CLL. The rest of the investigations that are suggested by the IWCLL guideline is practiced by some of them, but not by everybody. Bone marrow is done before in clinical practice. Bone marrow is not done in everybody before initiating treatment. 17P was done by most of the clinicians. Almost 24 out of 25 answered that they'll do 17P deletion, but rest of the imagings and rest of the fish cytogenetics is not done by all of them. Now, whether they follow any guidelines? No, none of them follow. Majority of them don't follow any guidelines, and there is no Indian guidelines. I've specifically asked whether there is any local or Indian guidelines. They actually follow. No. They all follow. If they are following some guidelines, they all follow the international guidelines. Do anybody conduct any clinical trials? None of them is conducting any clinical trials in UK, but around 25% answered that they're willing to consider clinical trials in future. So what do they treat patients with? So as a first line for fit patients, this is the biggest, this is what I wanted to highlight here. In India, FCR is available, and it's not, it's comparably more expensive than BR, but physicians tend to use BR than FCR in Indian settings. There is I'll come to that in later slides. There is a big issue around that. And in relapsed 17P deleted patients, they use still BR. I'll just explain this graph. The blue denotes that they don't use it, but the rest of the color denotes that they use it to certain percentage. So higher the chart, the higher percentage they use that. So you can see that BR again in deletion 17P, BR is used by several of them. Ibrutinib is used, but can't be used by majority of clinicians. Relapsed fit patients, again, FCR is used, BR is the preferred treatment, ibrutinib is used by some of them. And in slow-go patients, chlorambucil with or without the monoclonal antibodies, CD20 monoclonal antibodies is used, and BR is also used by several of the physicians. Now, what is the reason for not using FCR? That's the apprehension or the anxiety of most physicians is neutropenic sepsis. When I'm saying neutropenic sepsis, being trained in UK, I probably might not have seen such drug-resistant microorganisms that I see in India. So if I induce somebody for AML, I have deaths with multi-drug resistant gram-negative organism. When I'm saying multi-drug resistant, it's resistant to drugs like colistin, tigecycline, fosfomycin, so everything that is known to mankind. So that's what the anxiety. So the cost of treatment hugely goes up if they get a neutropenic sepsis while they're on the treatment. So that's the major anxiety of most of the physicians, and they're much more comfortable with BR. That's how the Indians treat CLL. allogeneic transplant will be considered by around 32%, and ibrutinib, 72% said that they will use ibrutinib, but I'm not entirely sure, the accessibility and availability is that high. Venetoclax is not licensed, but still can be used by around 16% said that they still use that. But I have to say that it's imported from some other country if that's not licensed in India. None of the other newer agents are available in India. Response assessment, clinical and hematological predominantly. Now, funding source, majority of them, is from out-of-pocket treatment. Health insurance and the government schemes are there, but it's extremely rare to get that. So these are the comments. I'm not going into the details of the comments in here because of the lack of time, I believe. But this is another slide I want to show you. It's a very faded slide. This is actually photographed from one of my case notes. This is the cultural aspects in India. We don't reveal diagnosis to the patient. We reveal diagnosis to the relatives. And with the relatives' permission only, we can actually reveal the diagnosis to the patient. So this is a letter I have written to a colleague of mine to see her, for a respiratory problem. I've boxed there. She doesn't know the diagnosis. And her son prefers her not to know the diagnosis. So the second slide, I just put that in that same context. I found, being transferred from one culture where patients know the diagnosis first to another culture, I found this tool extremely important. This tool is a universal practice in Indian clinics, whether it's a posh hospital or a poor hospital. It's still a stool where the patient sits. I found it extremely strange. The poshness of the stool may vary. You can have a revolving stool if it's a posh hospital, but this is from my clinic. It's a poor hospital. But I found this tool very important in revealing the diagnosis. So after I examine the patient, I'll ask the patient, why don't you take your seat outside in a comfortable chair while I talk to the relatives? And then I have to convince the relatives first that I need to talk to the patient, and then I have to bring back the patient. So I found this tool extremely important in my clinic in that aspect, but I don't know why in Indian culture stool is still there. So in conclusion, as my previous two speakers said, more epidemiological studies are needed before concluding that CLL has low incidence in Indian population. It may be right, but we need more evidence before that. Over the next few years, establishment of a real-world registry for CLL in India is one of my dreams. Advice and support and established registries will be very helpful, especially registries from the German group. Established registries will be helpful. Geographical difference in the incidence of the biology will help us to understand the pathophysiology of the disease better. So as I said before, like the Ugandan study, if we can have collaborative studies in Indian and Chinese populations, which are ethnically different population, we will be able to tease out the biology a bit better. Treatment of the CLL has to go a long way before it reaches the rest of the world. Cost of the new drugs are much beyond the scope of majority of Indian patients. We need to think about a different costing model for the countries in India. I don't know whether pharmaceutical friends are here. It's a country of 1.34 billion population. So the costing models is probably not applicable to developing world as it is applicable to the developed world. You can have the same income generated in the community if you diversify, or if you split the cost and diversify and made it affordable to more patients. This is an appeal to the pharmaceutical friends here. India needs to have its own trial portfolio to guide treatment for CLL in the regional population. We just merely following what's been said in the literature and what's been followed in the international scenario, but we have to have our own trial portfolio before we decide on what we should be doing for our patients. And collaborative research, especially forum like IWCLL, is a very, very helpful, and this is a very good initiation from Pete on including the speakers from the developing world in this aspect. And my greatest gratitude to my mentor, Professor Hillman, Andy and Gina, who has been my mentors in support, and Tal for all his support, and Nitin for providing me the data from Nedanda, and colleagues who participated in the survey, and my patients and staff and colleagues in my hospital. Thank you very much for your patience.